All right, folks, let's go ahead and get started. Welcome, the Department of Internal Medicine Grand Rounds. Today is April 4th, 2024. Today's session is sponsored by the Division of Hospital Medicine. And to introduce our distinguished speaker, let me introduce up Dr. Alan Dow, the Chief for the Hospital Medicine.
Applause is not necessary, but
It's not anything yet, but it's
Thank you very much. So great to see everyone here today. Very excited. I'm going to be quick because I want us to make sure we get plenty of time for our speaker. But our speaker today is Marisha Burden. So she's the Division Chief of Hospital Medicine at the University of Colorado and is a leader nationally in thinking about hospitals, about hospital medicine, about how we work as healthcare providers in the systems that we have. She's a figure on the national scene, hospital medicine and beyond. She's won multiple national awards for the work that she does. And just a treat to have her here. And I will let her impress you with everything she's going to say in the next hour. Dr. Burden.
Great. Thank you, Dr. Dow and the Division of Hospital Medicine and the Department of Medicine. It's a real honor to get to spend time with you all today and for this hour. Let's see if I can get the slides to advance. No, will that work? Oh, there we go. All right. Well, I'm thrilled to get to share with you all something I'm very passionate about, something I think about a lot, which is how we can think about working better and smarter so that we can optimize work for our workforce, our patients, and our organizations. So you heard about me. I want to just do a quick note of gratitude because a lot of the work that you'll see today is supported by a variety of entities, the Total Worker Health folks, the American Medical Association, and AHRQ, and I'm just grateful for the support. So we'll do three things today. We'll explore what clinical operations science is and why it really matters in healthcare more than ever. We'll look through a framework for designing and implementing effective workplace practices, and then explore a future vision of what healthcare could be. So I thought we'd start with a story, and I call it the $11 million question. And depending on who you ask, it was an $11 million question, or maybe a $12 million question. And I've changed the numbers to protect those who are involved. But it was a meeting that I had walked into, and they often say that one of your greatest strengths can also be one of your greatest weaknesses, and mine is persistence. And I was advocating for increased resources to support having more clinicians. And I had, I think, submitted probably about the 20th time via text, email, or multiple meetings, this request for, let's say, $12 million in total budget, which was an increase. And as I walked into a meeting, so in my role, I have a lot of bosses. And so lots of people come into meetings. And as we walked into this meeting, one of my counterparts came in looking very angry. And if they could have steam coming out of their ears, they probably would have. And I started thinking the naive part in me was like, gosh, they must have had a really rough meeting right before. And little did I know that I was about to walk in the meeting of my life, the one that would change my outlook on how I show up as a leader, how I think about resourcing teams, and thinking about outcomes. And lots of interesting things were said in that meeting. There was fist pounding, some anger about how the job was easy, that folks could do more, that turnover rates were too low, all sorts of things that just made my head spin. And what I realized in that meeting is that we were working with very different mental models about what success would look like and what was needed for success, which is best patient care. In this meeting, it took me months, years, maybe to come get myself back up off the floor because so many things were said that really changed my worldview and made me think about my worldview a little bit more. And it also caused me eventually to decide to go and get my MBA because I thought that maybe I was missing something, that maybe I wasn't understanding the full financial picture. And after getting that, and after years and years of contemplating that meeting and thinking about why did it go the way it went, is I think we have a fundamental misunderstanding, and you might call it an inaccurate accounting of how we think about our finances in healthcare and how we think about outcomes. And so the question that will be kind of pervasive in today's talk is, what is the actual cost when we decide how we staff things, how we build our operations, patient harm, organizational harm, workforce harm? And there is an actual cost, like a dollar cost, to not getting this right, in addition to the people cost. So we're going to start with the first part of this talk, which is exploring what clinical operations science is and why it matters for healthcare quality, safety, and efficiency. So I've got the pleasure of meeting many of you in this room, but I'll just do a quick poll in the room. And how many of you apply science or evidence-based approaches to your everyday work? Every single one of you. I don't even know all of you, and I know you do, right? There's so much evidence. We know how to treat pneumonia. We know how to treat DVT, diabetes, you name it. There is almost an overabundance of articles to know what to do. But my next question is, when you think about how you staff your clinic, your patient panel size, the number of encounters you see in the hospital, who can raise their hand that has an evidence-based practice for how they decide how they build work design? Oh, I would love to hear it. Yes, do tell.
So I think we've done some looking at what the data to substantiate the size of teams in ICUs with safety in mind.
Excellent.
Hospital management.
So you
There's a lot
guys
of work.
step ahead because most places I go to, not a single person in the room can actually raise their hand. So it's great. So my first foray into what I would call clinical operation science, which is like thinking about how we build things and do they work or do they not, started back whenever I was just a very young hospitalist back many, many moons ago. And I was working at our local safety net. It's called Denver Health. It's a lovely organization. And my mentor and boss at the time, Dr. Richard Albert, expected that we would build an academic hospitalist group. And with that, he expected that we, each of the hospitalists, would meet with him every single month to discuss what our research project was. Now, I was not a committed researcher, probably, or even a scholar at that point, because I didn't even know how to do it. But he was a little intimidating, or a lot. And so I showed up month after month because I was afraid that I might get fired if I didn't. But he helped me to start thinking about how we look at our systems and our work design and questions that people might care about. And he helped me learn actually how to refine and find a good question versus one that maybe was going to be of low yield. And so after about a year and a half of desperately searching for a project so that I did not get fired, I'm joking about the firing part, but I was nervous back then. I found a project that I thought was really interesting. And back then, the United Kingdom, and I actually think there was an additional country, it might have even been Scotland, had contemplated, and I know the UK actually implemented a policy called bare below the elbows, which meant in an effort to reduce bacterial contamination spread in hospitals, clinicians were expected to not wear things below their elbows. So the white coat, jewelry was effectively banned. And I thought that was such an interesting thing that happened across an entire country. A policy was rolled out without evidence. And so we decided to conduct a randomized control trial. This is my first project. I had no money. I partnered with the micro lab. I partnered with the laundry team to help me figure this question out. And we randomized folks to newly washed uniforms, which I tested and they were pristinely clean, to white coats in their normal dirty state, which is not really washed, but every few weeks at best. And at the end of an 8-hour workday, did you see differences in bacterial contamination? And we found that there was no significant difference. And then the next question was, well, what if you changed your uniform every 3 or 4 hours? But we found that it got quickly contaminated. So a policy was implemented at an entire country level that probably didn't work. And this was my first little project that I called the little study that could, because it ended up getting a press release. So a study that had no money behind it, a lot of blood, sweat, and tears. People cared about. So the Canadian press did a press release, got to talk with the Wall Street Journal. And so this was my first little foray into things that we do matter, and we have to study and make sure that they actually work. So there were several studies in between that one and this one, but then the next one, and this is less clinical operations, but more operation science, is that as a young hospitalist, I would go to national meetings and even regional meetings, and I would see that there was a lack of women speakers despite being what appeared to be a rather equal proportion of men and women going to conferences. And we decided to kind of test our hypothesis. Are there actual differences? And in our first study, we found that there were. And then we took advantage of a naturally existing experiment where a large national society implemented an open call process, which means anybody can apply to be a speaker. Does that influence the disparities that we were seeing? So an organization rolled out an entire policy and we tested it. And it turns out it eliminates disparities. And you can see that in the bottom right. So a couple more studies later, as I entered leadership in a very sort of early career kind of way. And I think almost every hospital, whether it's in the United States or even across the world, is plagued with capacity issues. We have more patients who need access to get care, and we can't seem to quite manage it. And when we have trouble like that at the organizational level, we throw everything at the problem, the entire kitchen sink. And so some of those strategies that we use are huddles. And I was giving this talk where somebody said that they had to go to 3 separate huddles in a day, like physically go to that. Is 3 too many? Is 1 too little? Who knows? Discharge before noon efforts. Lots of organizations love thinking about discharge before noon and different strategies around that. Maybe geography. Workload has actually been shown to impact it, but no one wants to talk about that because it is perceived to be costly. And then incentives, and there are interesting articles around what incentives may do around that. And so we decided to question, whether a commonly utilized strategy across the United States, most hospitals probably across the US, utilize some strategy around early discharge, whether it's 10 a.m., 12 p.m., but sometime. And then we use strategies such as texting folks who are busy clinicians just to remind them that they're busy and that they need to discharge before X time. And as a leader, I sent those emails, I sent those texts. But I started to question, is that effective? Mostly because of the reaction that I would sometimes get to those emails and those texts. And I knew as a frontline clinician that it was not helpful. And so with funding from AHRQ, we decided to conduct a randomized control trial of prioritizing discharging patients first as the sole strategy. Is it effective? Does it improve throughput, which is effectively length of stay? And no matter how we looked at the data, the intention to treat analysis, how people rounded, what we found in the end is it did not improve length of stay. Now, the one caveat to this that I'll share with you in a bit is this is looking at a single strategy, but at least a very commonly used strategy across the US did not seem to help. And then what we found in the qualitative comments were really interesting, and I'll focus on the upper right. Irritated, all caps, I didn't do that, the participant did, that I rounded on the discharging patients first, knew they wouldn't be able to leave until later in the afternoon. By rounding on them first before I had all the necessary information, I was misguided when putting in discharge orders and counseling the patients. I had to see both a second time. And so the suggestion of rework and wasted effort came up in addition to frustration. So when we think about these organizational wide strategies, pretty blanket wide approaches to very hard problems, we sometimes apply these and we don't exactly know the outcomes. And sometimes they can actually cause harm. And I think thinking about clinical operations science is more important than ever as our healthcare organizations face a lot of challenges. And in the research I do across the entire country, these are things I hear and see. Is that individuals feel like there's sometimes conflicting goals, that maybe profit over people is sometimes a common thing. We have limited resources. So as an idealist, this was a very sad one for me, but we can't have it all. So we have to make tough choices. And then when we throw uncertainty we all face, it can lead to less than ideal decision making. And we do these blanket approaches that we don't know if they actually work. So I thought I'd go through a couple of the articles that have been kind of hot off the press over the last few months just to characterize where healthcare is. And I'm sure every single person in the room feels these things and knows these things. But I think it sets the stage for important conversations about why optimizing work design is so important. Now, if you are in the clinic, I don't know if you all have seen the JIM article where PCPs, if they were to follow all the evidence-based guidelines in clinic, it would take more than 24 hours if they were to have to do that alone. So what that tells me is folks in the clinic have a nearly impossible job, right? You're tasked to do more than you actually have time to do. And then in the bottom left, if you're in the inpatient setting, what you see is patients are getting more and more complex. Yet the rounding models and the staffing strategies are almost the same from when I was in residency a very long time ago. And then further adding injury to all of this is that our workforce across the country is in a pretty rough place with high burnout rates and high intention to leave their jobs, which indicates to me that we have an unstable workforce that we have got to work on to make sure that people are thriving and happy in their workplace so that we actually have a workforce to take care of our patients. Adding further chaos to this mix is our academic medical centers are changing. And so we had this article in the Annals of Internal Medicine where we looked at how the clinical mission, which I think many of us are seeing growing, which is great, but also our academic mission feels like it is not always growing at the same pace. So for example, what we heard is residency programs are kind of not growing, yet the clinical mission is. And so, how do you prioritize sort of this supply to demand mismatch? And it causes some conflict and the sense of strain in the workplace. We conducted really rapid focus groups across a very large number of organizations, 32, through the Home Run Research Network. And this is a survey embedded within the qualitative interviews where we just wanted to get a pulse on what's the organizational feel, how do people perceive what's prioritized. And what individuals from 32 organizations said is that when we looked at my healthcare organization prioritizes clinician health and safety to a great extent, only 6% of people felt their organization did so. My organization encourages transparency and accountability in decision-making, 9%. Now, this far-right category includes sometimes and to a great extent, but I have witnessed instances where administrative harm has led to adverse patient outcomes in my healthcare setting. And administrative harm, we'll talk about a little bit, is organizational decision-making, and it can come from anyone, clinicians, administrators, et cetera. But organizational decision-making, decisions can lead to harm. So that is like the depressing part of the talk, and we're going to move into the hopeful part 2 and 3. So I hope to share with you a framework for thinking about designing and implementing optimal or effective workplace practices so that we can hopefully all thrive. So for quality improvement enthusiasts, this model should look very familiar to you, but it's structure plus process equals outcomes. But it is a framework that we forget about when we think about how we optimize work design in our clinics and in our hospital. And for me, this is like what I live and breathe. And I think about if we want to improve patient outcomes, if we want to improve burnout, if we want to improve the financial bottom line, then we have to start thinking about work models and environments and our work processes, or we will never get to the right side of the equation. And it gets to this, for me, the Starling curve. I found this online and I loved it because I think when I go into meetings, folks are often like, well, why can't you just see more? Why can't you just do more? And sure, I'm sure we can, right? Until we break or patients get harmed or financials get harmed. And so how do we optimize our workforce and not break us is the big question. So this clinician is alive. They are just not thriving. They have been harmed. But the way I think about this is this picture, which is if we don't get our work design right, I think we have to start using and contextualizing this in the form of it is harm. We think about it from patient outcomes. Now we have to start thinking about it from organizational decision-making. It leads to harm when we don't get this right. So I thought I would share with you a couple of articles. These are a little more hospitalist focused, but I think the trends are, no matter, they're, I think, consistent no matter what the field. But when we look at workloads, we know based on literature, I would say mostly in the nursing field, is that when we push people to too much, when they're tasked to do more than they can actually handle, harm starts to happen. Patients die, nurses want to quit, high burnout, and job dissatisfaction. In the hospitalist world, what you see is that there is a workload threshold at which then length of stay starts to go up. And there's really great articles actually in the business realm on this very topic that shows when you don't get this right, it can cost you millions of dollars. So it's interesting that you can sometimes see at the organization level, do more, do more, do more. And our other strategy and initiative is reducing length of stay, which the two compete with each other. So you have to try to get to just right. And this comes from an annual benchmarking report, which I think Society of Hospital Medicine does a really great job of. So we have a lot of data in our field. And it also shows that when the patient numbers start to get too high, that the sense of safety for patients starts to decline. And then lastly, workload drives burnout. So when we think about all these efforts that we do at the organizational level, if we're not thinking about work structure, workloads, et cetera, we're not really looking at the full equation to understand how we improve burnout. And this is just a schematic that in my mind, these different things drive burnout. And so thinking about workload, time pressures, environment, shift work, et cetera. So the other interesting thing is that when we think about driving outcomes at our organization, there are many things that can impact patient outcomes. And so in the hospitals world, an interesting thing is the more experienced you are, the better your outcomes. In particular, in that first year is where we see increased mortality. And so we know that our workplaces are driving increased turnover and burnout. Yet, by keeping people, we'll get better outcomes. We're also learning, in addition to the workloads, that patient complexity also drives some of the outcomes. So for more workload with higher complexity patients, that it's actually more than just the patient complexity that's driving it. It's complexity plus workload. So we have to start thinking about complexity and workloads a little bit together. And this is the article I was mentioning that in the business world, I don't think it shows up in PubMed when you search it, but in the business world, you can use this link. I think it's really interesting because it gets at that value equation of like what's too little and what's too much, and how do we start to get to the sweet spot? And this equates to financial dollars when we don't get it right. With the inevitable question being, I get this in many meetings, how do we squeeze more juice from the lemon? And the reason why we think about that is because many organizations across the country are also facing financial constraints and concerns. So these conversations are tricky because I think inevitably people are like, oh, it's more resources, it's more money. But what you've seen in some of the data is actually when we don't get this right, it may actually cost you more. And so this is just an example from the Colorado Hospital Association where you can see that expenses are outpacing the patient revenue, which is why it drives some of these stressful conversations and the friction that you might see in a meeting about $11 million versus $12 million. And so how do we start to think about costs and trade-offs? We're really good about thinking about it in the short term, maybe a couple months long. But when we make a decision today, it's very easy to forget to look about, we didn't approve that additional million. What was the consequence? Did it cost us more? Did it cost us less? Did anybody die from it? Did people quit? And so how do we start to think about these outcomes in a different way? And hopefully to advance the science of work and implement best practices. And my goal is to think about this in a much more holistic way. And what I see in healthcare and in my leadership roles is we have our financial colleagues over here looking at the dollar amounts that we don't often equate and think about how it drives the quality outcomes. We're looking at well-being over here, but not thinking about, okay, how is work design also impacting that? So taking a much more broad look at things, implementing things, rapidly evaluating them, and thinking about them in both the short and long-term sense. And so the key questions that I think about is stuff I dream about because I love to think about it a whole lot is how do we get the right model, the right workload, the best outcomes, and for it to be financially viable? And I think we can get there. And so some of the tools that we use, I often get asked in the hospitals world, how do you do research? How do you do these like large scale studies? But many of the strategies we use are easy. Like it's sort of a see one, do one, teach one. We do a lot of work in the rapid qualitative analysis world. I could take 20 minutes and teach any and everybody in this room, if you didn't already know it, how to utilize these methods to understand how your operational practices are driving things. So rapid qualitative methods, we use Delphi panels, workflow analysis, electronic health record innovations, all this stuff is in our toolbox and readily available to most of us. You don't necessarily have to have a fancy data team to do this work. So I thought I'd walk through with you the strategies we've taken, which is still early in the game. I feel like this is like a decade or two or three of work still yet to do, but how we've started to think about workload, how we might optimize it and get to what is the sweet spot, recognizing I don't think there will ever be a blanket answer of X number because you have to take into account what's the complexity, what's the model, what are your goals into any sort of equation. And so when we started this work, we started thinking about what are the measures, thinking about traditional measures, but then also starting to think outside the box. How do we get the data, which is often a big question? And then what are the outcomes that we care about? So when we started thinking about what are the measures, and we always think about all of our work in both a scientific way, because I believe that we should, and then also in an operational way. And so research and operations is very murky for me because I do both kind of at the same time, informing my division head work and then also my division head work informing the questions. And so what are the standardized measures that we have today? What is expert opinion on the topic? Because we have to think about that as well. And then are there any emerging best practices we can utilize? So when we started thinking about this, we started with hospitalist work, and then our dream is to expand even beyond. Decided to do a scoping review. And if you ever decide to do a scoping review with the word workload, I would say avoid that project. Very painful, 6,434 articles. And sadly, what we found is kind of what we knew whenever we first started, which is there are many measures of workload. There are plenty of generic ones. So work review, time, encounters, we all know those. We use those today. There was a little bit of innovation, and this is now, I think about a year and a half ago when we finished the review, and we'll talk about some of that innovation that is now coming into play. There are so many articles, but no clear answers on how we should think about this, yet many impacts. So patient safety, clinician outcomes, organizational outcomes. So then we turn to experts, both within and outside of medicine, human factors engineers, chief medical officers, frontline hospitalists, advanced practice providers, to help us think about if we are going to start thinking about workload in a much more holistic way, how should we start to measure it? Similar to the scoping review, we got 192 unique measures, which is about 182 too many. But it's great because it made us think really broadly with our goal then to kind of distill the data down. And ultimately, in round 2, we got 6 measures that were considered highly relevant, 25 moderately relevant, and then you go back through the process, and we ended up with about 25 highly relevant and 95 moderately relevant, which is still way too many. So here are a couple of the measures. So you can see folks thought complexity scores are important, thinking about outcomes like burnout, savings from hospital days avoided, et cetera. And this is like a more complete list, but it still keeps going if you get the paper. But there's a lot here to think about, many of which are probably important, but our goal is to next then look at how all these different measures and to see which ones are actually the most important. Because again, what we want to take this and move it to is something that any organization across the country could then utilize and not have to have fancy data folks to figure it out. And then what we also heard in the comments is when we're thinking about measures, folks wanted to be within the locus of their control. And then one comment is, care should be taken to not incentivize having a high census, as this could inadvertently disincentivize discharging patients. So again, be careful about what you incentivize. So there's all these like kind of catch-22s and different things that we should think about. So from that work that was funded by the Total Worker Health Award, our takeaways were traditional measures are likely insufficient because we're not in a great place. Nobody has quite figured this out. That measurements have to involve more than just counting things. So it can't just be how many work reviews did you do today? How many encounters did you do today? It needs to be paired with like, what did that then drive? And so a much more comprehensive and nuanced approach is needed. So I thought we could just take a little quick dive into what Rapid Qual can do for you. We have a paper in the Joint Commission Journal on Quality and Safety, and it's like this nice little guide. So that if you implement something in the clinic or in the hospital, you can use this as a strategy to get a quick pulse on how things are going. And we've had a lot of luck in publishing these. We run kind of concurrent sessions with lots of folks, often nationally, so they're usually multi-site. But for example, in the middle of COVID, when we implemented new strategies, we actually utilized this. And then as a division head, I don't get to do the interview, so I am blinded to that. But we got to hear, did the strategies that we were utilizing work? How was our communication strategy? How am I showing up as a leader? Did the surge plan work as hoped for? And we distilled that down to key themes. And then we utilized that as our playbook of what to do better and then also what to keep that was working. And so we've utilized these methods in so many different workforce arenas. So the COVID surge adaptations I mentioned, we were curious how it impacted women in the pandemic, workforce priorities, backup strategies, parental leave, thinking about leadership safety, health, and well-being. And the list goes on, and there will hopefully be like a fun article coming your way around administrative harm, which we'll talk about in a little bit. So as we did all this work to define measures and start to think about outcomes, which will be next, we decided that we don't have a great way to get a pulse on what work models are driving. So we often do, an annual or every 2-year survey on what's your burnout, what's the culture of safety. You don't get a real good in the moment pulse on how things are going. And so we built something called Gritty Work, which is like my side passion, my project that I think about and optimize and try to improve honestly every day. And then we're adapting now for house staff. But it's a nice little app that you can get on your phone, and we ping people at very strategic times to sort of understand, how was your workday today? In the pilot, we over asked questions. So we wanted to standardize and make sure it was actually legitimately capturing the data we wanted it to. And then we also looked at something called event log data, which is electronic measures of workload and other things in electronic health record. So we ran a pilot of over asking questions, but to understand, would people, one, engage with an app? Two, would they be honest with us? And then three, were the data that were captured, were they accurate? This is just a quick snapshot. This will also be coming to a journal near you, hopefully soon. It is accepted. And so this is a snapshot of what we saw during a 4-day pilot that we ran essentially over a month. But if you were on service for 4 days, we asked you, we pinged our workforce to tell us what they thought. So you can see hours worked, how many patients they were responsible for, what the NASA task load is, happy or sad, shift rating, feel burned out, et cetera. Now, the interesting thing when we did this, we thought we just maybe got more happy folks, but we just got our organization-wide survey and it actually matched the burnout data. So there was a nice linkage to that survey where we had like an 80% response rate with the data that we got on a pilot. So we got several insights about how people, one, what they thought about the app and what would make them either decide to engage with something like this or not. And it fundamentally came down to two things. Do you have organizational psychological safety? And if I give you data and take my time to give you that data, will you actually do something with it? And so you have to have mechanisms where people feel safe and they feel like they have a culture where somebody is going to use that data, hopefully for good. So now we'll jump into the part of how to leverage data to improve daily work and build future of work. So this gets to the outcomes. And when I think about outcomes, as a division head, it's easy to get caught up in the financial. It's easy to get caught up in the productivity measures. But as we get back to that holistic viewpoint, we have to think about our people outcomes, our patient safety and quality outcomes, and we obviously have to think about our organizational outcomes, which include financial ones, which are also important. Towards making data-driven decisions. And my dream is that we can passively collect data, actively collect data as little as necessary so that we're hopefully not busy bugging busy clinicians, thinking about how we can harness the power of the electronic health record because there is so much data that is just there waiting to be used to optimize work. And then taking an approach that's called a total worker health approach, which is again, how do we support our workforce to do their best work so that they are healthy, that they are not overworked, and that everything is going hopefully in a direction that is just right. So I don't know if those in the room are familiar with, it's called audit log data or event log data. And so major electronic health records, actually I think all electronic health records, keep track of who enters a chart. And that was like required when electronic health records were kind of first deployed. Now within that, the cool thing is that we can actually access that data. So it's clickstream data, mouse data, anything you do in the electronic health record is captured. And you could start thinking about how do you use those patterns of data to understand then what a design, a work design might lead to electronically, and then thinking about outcomes. So this is what Epic signal data, so this is more aggregated event log data, I can just go to, and I'm not a data analyst type, I'm not a fancy data scientist type, but I can actually pull this and understand what different clinicians' work patterns were, or groups of clinicians' work patterns were last week or the week before. And as a hospitalist clinician, when I look at this, it rings true. So you see the first part of the day is in clinical review. There's a dip during time when we're going to round, and then you're doing notes and other things in the afternoon. But this data seems very cool to me. We don't have to ask anybody to do anything other than their regular work. And then when we implement kind of cool QI projects, we can see how it might impact someone's work or a group's work to understand if something worked and if there were adverse events. And there's some initial studies, a little bit more in the outpatient setting, looking at audit log data and outcomes such as burnout. So when I think about evidence-based work design and a data-driven approach, what might that look like? So we have the mobile application, Gritty Work. We have electronic health record that is actively collecting patient data. It's actively collecting our work data. And then how do we connect that then to what that means in the way of like how structure and process then leads to outcomes. And so here's kind of the conceptual model for the work. You have intermittent, thoughtfully deployed surveys, not very often, hopefully, into a select group of individuals to hopefully get an accurate pulse on the group, whether it's clinic or hospital. You pair that with the clinical and electronic health record workload data. The next thing we're working to dream on building is then this hubs into an actionable dashboard so that when I go back to that $11 million or $12 million question and say, here's going to be the impact of that decision, maybe a patient dies or our burnout rate's going to go up by 10% or 20% or the turnover rate's going to increase. What is it going to do? So that we can actually monitor for harms and provide insights to optimize workloads in as near real time as possible and not wait for the disastrous, well-being survey results that come out 2 years from now that we didn't even know what was brewing. So one thing I think is important in this work is that the exciting thing about work is it's changing dynamically. There are all sorts of cool devices and tools now to facilitate our work. I'm very excited about these ambient listening devices. I don't know if you all have them yet. I am chomping at the bit to get them in the inpatient setting to help us make our work hopefully more efficient, maybe even better. Thinking about AI, it's just so cool. I think we'll be able to work faster and smarter and better. But again, going back to the fundamental process plus structure equals outcomes, when we implement these tools and strategies, the assumption, at least when I look at these business models, maybe people don't outrightly say this, but the assumption is you're going to do more because your time is replaced. So how much more can you do, until you break? And the goal is to not break, right? To get to optimal work design. But these tools and strategies and changing dynamics of teams will impact what the work model looks like and what the outcomes are that it drives. So this is the last little section that I want us to think about. As we start to get data-driven practices and hopefully build evidence-based practices, we have to start thinking about how we make organizational decisions. And I don't know everybody in this room, but I would assume almost everybody in this room is either a leader in a formal way or even in an informal way. So when we lead teams, we are leaders. And if you're on a committee, you are leading. And sometimes those committees actually make decisions. And so if you don't speak up or you speak up on part of an issue, you're making a decision that will impact outcomes in the future. And so I'm very interested in how organizations and organizational leaders make decisions because I think we can probably do it better. And there's a really interesting article. It's now a couple of years old from the New England Journal of Medicine. It's a really interesting read. If you haven't looked at it, I was surprised that it didn't get as much of attention as I thought it might, having now seen it in the past year or so. But it talks about how we can do better, how we can collaboratively work with non-clinician administrators, clinician administrators, and frontline clinicians so that we have a much more holistic understanding of what a decision will lead to. And we do this in the clinical space, right? When a patient gets harmed, we have a whole process, right? There's a place that you can go to log it. Then we convene and we do a root cause analysis. We do all these processes to understand why did something go wrong. But when I look at my role in an administrative way, when I make organizational decisions, decisions that impact my team, we don't have those processes in place, not unless you're very deliberate about it. And so when I think about this, when we get this wrong, there are real consequences. And these are just 2 quotes. So all the research I do anymore is very frictiony. We talk to people across the country, and what you get is a sense of friction, that people don't feel like they're working well together. And it feels pretty pervasive. And we do research across many, many organizations. But here's a couple of quotes that highlight this. We answer to 2 kinds of bosses that don't necessarily talk to each other. There's the hospital and our commitment there and our clinical commitment there to serve the patients. And then there's the School of Medicine or our department who then are more responsible for that academic side of our growth. And those 2 don't necessarily talk to each other and in many situations don't have aligned goals. And then the next quote is about sources of strain. There's less give in the system and you just feel this tension in literally every study and interview that I do. And so from this work, I started thinking about how can we make better decisions. And the big we, I am an administrator, I'm a clinician, and getting back to that concept of whether you're an informal or formal leader, we're all making decisions that can impact workflow, work design. And so how can we start thinking about bridging the gap from when we make a decision to understanding the outcome? And what we learned in our study of administrative harm, and this won't go into detail, hopefully you'll get the paper in the coming months, is that there are some barriers to better decision making. We don't have processes to detect when things go awry. And then the higher up you get in a leadership role, the more kind of distance you are from the impact of that decision. And then the less people are actually inclined to give you feedback because they don't feel like they have the psychological safety to do so. And then the front line will do workarounds, of which the high level leaders don't understand because they're not boots on the ground. And so how do we bridge this gap of like all good people here, not necessarily understanding the issues that each other are facing to make better organizational decisions with hopefully our evidence-based work design practices that we're building. So what does this look like in practice? And I'll just share with you kind of at a high level about how this is going in my own division, is taking what I think of as a learning health systems approach to optimal work design. And so as we make these decisions that impact job demands and job resources, there are certainly some individual factors that will influence some of these outcomes, but mostly I look at it from an organizational lens, from a divisional lens. This leads to either burnout or not, and job performance, which is clinical outcomes. And so we've started implementing as we speak, working to build a system to monitor in rather real time, it's not exact real time, but near real time, using the Grady Work app, event log data. And then our dream is to understand what services are like the hotspots. Where is it not working well? When you add a student that's maybe like a high needs type of learner, how does that impact your ability to actually take care of a certain load of patients and tend to your jobs as an educator? And so hopefully we can start to bridge that gap to make data-informed decisions, better decisions, and hopefully in a shared sort of way. So what does success look like? This is what it looks like to me. I'd be curious as to what you all think, but we need to have a shared understanding. The fact that there's friction in every focus group I do around workload and workforce, I think it's because we don't have shared mental models. So how do we bring us all together so that clinicians understand financials, that financial folks understand the impact of workloads? We have to build trust and transparency. That is not an easy thing, but I think data can help us do that. And then using data to help inform our strategies. And with that, I will conclude and just a quick note of gratitude. Thank you.
We'll start with any questions here in the audience, maybe?
So I always love hearing you speak. It's great. And as you think about students or residents or even junior faculty who are sort of entering into this world of work, and we kind of protect them from it all the way through, and then sort of act like, wow, look at all these things going on. How do you think about how we should be educating, training, preparing upcoming workforce, or then now entering the workforce as independent providers to be able to succeed, where you're right, the organizations are not always as supportive as they should be?
Yeah. Well, I don't know. I love my job. And so I think there's like great opportunity, you know, and what we always try to get our, I think, especially in our hospitals training track, which we have, is to really help clinicians understand they also have a voice in all of this. And so like, how do you kind of integrate into the system so that it's not an us versus them, because we can't really function like that. And I think we function like that now, the big we, right, across the United States. Because there's this financial part and people see that, right? We have to have our financials in place. So how do we have a conversation that's healthy around ensuring financial viability? And at the same time, I think how we think about our finances is probably not entirely accurate, right? So we see untoward outcomes that happen when we don't get it right. So my question would be, how do we like all come together to have better decision making? And when I see some of these very high level decisions around budgets, we often don't have a frontline workforce viewpoint, right? And so I think it's thinking about ways to kind of integrate folks who have different jobs for more of a shared understanding. And I think in training, it's a great way, like having more trainees on committees and thinking about those kinds of things. And then I hope data will bring us closer together, but maybe not. We'll see. But that's my hope.
I think maybe a counter to that, if you will. I think there is some data to support training in an optimal environment, so that when you enter into a less than optimal environment, not that it's optimal, I'll say in training, but trying to
Yeah.
protect structures as much as possible so that you can develop those skill sets allows you to succeed when there are additional challenges coming at you when you're not protected. I don't know if you know, can speak to that at all.
Yeah, well, I think building like my whole life is around structure and process and how do you build optimization and I think that the interesting thing in particular, and I assume clinics have their own version of chaos, but in the hospital setting, you can't predict your workday at all. And so I struggle with that because I'm like, how do you build predictability in an almost unpredictable system? And that's what we've kind of worked to do. And I think you see this in academic medical centers where there's maybe thresholds, right? There's caps where we know we're not going to exceed a certain level. And I think that gives people the sense of predictability in an uncertain system. And then I think for us, what we learned in the pandemic is people just like to know what's going to happen next, that somebody has frankly thought about it and then communicated. And I will own that as a leader, I try to be very transparent, but you're making so many decisions, right? That you forget about like, oh, I talked about this with my core leadership team, but did I actually share it beyond the group? Because they probably didn't see all the thought that went into a decision that maybe was less than ideal. But I think trying to think about how we get better also at conveying why we made a decision and the data we had to make that decision, because a lot of it feels very opaque. And so again, thinking about how do you build that stability in a system that is frankly not, but that perception of, right, that the leaders care, they care about me as a person, they care about the patients, here's how they make their framework for making decisions. Because I think what folks feel now is that it feels more about profit making over all else. When it's not really the goal, right? I don't think that's anybody's goal, financial or otherwise, but you do have to make a profit to keep the lights on. So how do you have that conversation where it feels like you're thinking about things and you actually are thinking about them holistically? But when you look at a budget in terms of dollars only, you're not getting that full picture.
Do you think though, to piggyback off both of those conversations, do you think that there's maybe some benefit in starting in residency at least and focusing on efficiency and focusing maybe on some of this pay structure and financials? Because at least for my own residency, we didn't do any of that. I was lucky enough to become efficient.
Yeah.
I think that helps with some of the burnout.
Yeah.
But I feel like that's something that maybe we hit it maybe at the beginning of training and then that kind of carries through.
I think it's a brilliant idea. And then also like people who maybe somebody is like, oh, not me, I want less of that. But thinking about, we have like a hospitalist training track, for example, where you do get a little bit more of that. But I think it's like a great idea to like kind of think that way for that shared understanding. And then, my MBA was more in healthcare, but like just thinking about how do you also influence business training, to sort of say, okay, you can't just look at the financial bottom line. It's got to be that and other outcomes. So I think we can probably both do a little better. Yes.
Go ahead.
Thank you, Dr. Byrne. I have a question. So I like this evidence-based approach to operation or clinical operations science. My question is, what do you do once you get this data? How do you go about, I guess, aligning yourself with the organizational ends goals when perhaps they don't even speak that same evidence-based language that you do?
Yeah. Well, I think we speak possibly more of a common language than we think, but I think it's all in the pitch a little bit too. And so to me, I think we all want a workforce that's stable and thriving. We all want financial outcomes. We all want better patient outcomes. And so the way we use this data today is when we get a signal, then we look to say, what do we need to change? And that is not just through like a survey, right? So like there's other best practices. So every Wednesday I do leader rounding. I'm like, what's the pulse on the group? Are things working? And I intentionally ask, I'm like, what can I do better? What can we do better? To iteratively improve whatever I hear today, ideally today or tomorrow. And what I see is that it works. Like our well-being scores, that's one focus of many, have improved dramatically because people feel like they do have a little more control over their workload. We have intentionally worked to reduce it a bit. And, there's other outcomes though, right? Like length of stay, optimizing team structures. There's like so many things within this. And so to me, it's like iterative improvement. And then when it's working, keep doing it, and then making sure that it also ties into that financial equation of viable.
Just a little quick aside. I had like a 5-hour drive in February, and about 5 minutes after you started speaking, I had a deja vu moment. I realized I had heard your podcast with Dr. Centaur
Oh, yeah.
in the ACP panels on call.
Yeah.
So this was great to kind of have another go at this. My question is, I think a lot of us, I think something you and Dr. Centaur talked about was that we're all off in the educational sphere. A lot of us are very kind of type A people. We want to do the best at everything we do. How do you talk to your colleagues, and maybe how do you also talk to your trainees when you feel like you're having days or moments where we're not reaching that that educational piece gets put to the side because of the clinical demand?
Oh, that's hard. You know, and I think you're going to always have competing demands. That's probably a skill set in of itself. So maybe a conversation around that. And I don't know if I'm as deliberate as I should be on that, to be honest. I think we all, you know, the thing that gets pushed by the wayside, right, when it's busy is patient care first. Education, you know, you're going to help a patient who's sick. And so I don't know if I have a great answer for that, but I'm going to think about that a whole lot. Yeah, it's a great question, and something that I think trainees and attendees alike will face. So it'd be a great perspective piece, actually.
Ooh, challenge.
I have one or two questions online.
Okay.
Just show you. Hold on. Let's see. Well, we can show everybody so they can see the questions. Do you have any comments on those questions?
Yes. Should I read it out loud? Just
They should be able to see it.
okay, everybody can see. Oh, good. Okay. Yes. So ambient listening devices, aided by scribes. Yeah. So I think it's very interesting. So I, in that space in the inpatient setting, at least the 3 companies I've chatted with desperately, and I'm very persistent also with that. They don't have the capabilities, or at least most of them don't, in the inpatient setting. So I'm not sure there, but I've heard some good things. I've also heard that the documentation can be overly wordy. My hope, though, because I love AI, love ChatGPT, to use it in the right ways. But I think there's hope that these types of tools can actually really hopefully get us a little bit more to the bedside and more to that deep work that I think we're all in the field for. But I think this is where the evidence-based work design is going to be really important, because these tools are very expensive. I think somewhere around like $600 per person per month, kind of expensive. And when I see that on the business side, I'm like, okay, well, nobody is going to be willing to pay more money on top of what they're already paying. So then you have to assume there's going to be more collections through more encounters or more visits. And I think the question is like, how much more can you do, but still hopefully get clinicians a little bit more back to the bedside. And for me, like what I miss in my clinical work is like, it's very hard to do deep thinking, deep work to really contemplate a patient, because you're just running all over the place. And I would love for these tools to help with that. But I just see what ChatGPT can do kind of in some of my academic work. And I'm just really hopeful that it can maybe transform our work, but thoughtfully so that we're not, you know, seeing 100 patients a day or something like that. Unless the data say we can. Just kidding.
We probably have time for one or two more questions. Anybody else? Yes, in the back.
I appreciate your thoughts on transparency with your team, especially about the hard decisions that kind of go on in the background. So how are you actually sharing that with your frontline team members?
Yeah. Well, I mean, I think we share in a variety of ways. Could I do better? Yes, I will own that. I can always do better. But when I do work rounds or walk rounds, that's like an opportunity for people to ask. We really take a very transparent approach to like every decision. And so we haven't got to the point of like, we share everybody's salaries and FTE. I think that would be like a real culture shift, but it's almost everything but that. But for example, around salaries, we decided to have a band system, and we're like, well, we're not going to just push this out in an email. You can come meet with us and you can see the band. And that was a real culture shift. But it's like, if you're 3 years out of training and you're, assistant professor year 2, possibly, this is what your salary will be. Everybody's salary is going to be that. So when you sit with your colleague in the workroom and you ask each other, do you have the same salary for the same job? The answer should be yes. And if it's not, then that's an administrative error on our part, and we'll fix it like today. And so that's just an example of like, here's a new thing we're doing. Here's the framework for what we decided. Here are the disparities. We actually even published that very openly in Journal of Hospital Medicine. And so it's sort of like, I assume all data is free game, mostly being thoughtful about patient data or, kind of private data, but everything else is like, here's the data we had. Here's the decision we're making. Ideally, I'm not making that in isolation. So we have flash mobs is the term that we use, which means there's a hot topic. We'll all come together either virtually or in person. And we did that for salary. We're like, we have an inequity problem. So how do we think about this? And we hashed through it. And then ultimately a smaller group of folks made decisions based on that feedback. Those are just some examples. But I think where I can do better is like sharing the actual data with folks in a more deliberate way. It gets at that sort of everything's moving so fast, 1,000 miles an hour, and you forget, even though you're like small team knows about it, but not all, 150. So it's easy to get caught up.
Maybe AI can help you share the.
Can
data.
remind you, like, did you share the data?
Okay, anything else? Thank you so much for coming.